Hello everyone, welcome to this Neurology Journal Club. My name is Linxin Li. I am a clinical research fellow at the Wolfson Center for Prevention of Stroke and Dementia at Oxford University. I'm joined by Professor Sarah Pendlebury, who is Professor of Medicine and Old Science and Old Age Neuroscience, also from the Wolfson Center for Prevention of Stroke and Dementia. Welcome, Sarah.
Thank you, Linxin.
So today we are going to look at this paper from Dr. von Sanderwold and colleagues on association of cardiovascular risk trajectory with cognitive decline and incident dementia. So cardiovascular risk factors, as we know, have been associated with dementia, including Alzheimer type of dementia and also vascular dementia. But of course, vascular risk factors do change over time, and people's control of vascular risk factors also change over time. So the authors of this paper hypothesized that different individuals may have different trajectory in terms of their risk factor over time, and this may then translate into different risks in terms of their dementia over time. And what do you think is the sort of unique aspect of this hypothesis, Sarah?
Yes, well, that's a very good point because, I mean, we've long known that vascular risk factors in particular are risk factors for dementia, but I think the interesting and novel aspect of this paper is that they've tried to look at a more real-world evaluation of vascular risk. So, in other words, how they're changing over time in an individual. And that's also of particular interest in terms of thinking about what will happen if we can intervene to reduce vascular risks and to address modifiable vascular risk factors. So I think that's the key novel aspect of this paper.
Excellent. So we're very excited to then dive into the paper and see first what participants they've included in the study. So they've included healthy people, so people without cognitive decline or dementia at baseline, from a population-based study called the Petula study from northern Sweden. They included two samples, one from 1988 to 1990 and the other from 1993 to 1995. For each of these samples, they recruited 1,000 individuals, and they thought very carefully. So in these 1,000 individuals, they had 10 groups of 100 participants evenly distributed across age ranges between around 35 to 40 to 80 to 85. And they also had even sex distributions. However, not everybody had complete data set, and not everyone was able to provide follow-up data. So they ultimately only included, out of the 2,000 participants, 1,244 who had sufficient data and attended at least 2 time points in the current paper. So Sarah, what do you think of this sort of participation rate to some extent, about 62%, so 1,244 out of 2,000? Is attrition common, and could it produce any kind of bias, for example?
So the first thing to say is that this study is using a healthy aging cohort, you might call it. And these types of cohorts are very common in this sort of longitudinal research. But as you point out, one of the big problems is who gets into these studies at first, and then who is retained within them. So you referred at first to the fact that they started off with a planned sample size of 1,000 in each arm. But in fact, they then only included 1,244 in the final analysis data set. And that selection occurred because they needed to make sure that they had people with at least 2 data time points. So, I mean, what we know from other studies is that, generally speaking, you do get selection, even if you don't start off with specific inclusion and exclusion criteria. And that happens sort of indirectly because the people who are less likely to attend for follow-up tend to be the ones who've developed illness or have other problems that mean they can't continue with follow-up, and they tend to be a higher risk group. So we need to be aware that there may have been some selection bias here. Yes, and then the other problem, as you allude to, which in some ways is even greater, is the issue about keeping people within these longitudinal studies. And we know from other studies that there is always attrition. You can't do anything about that. Some of that attrition is death, which obviously is unavoidable. But in terms of loss to follow-up, there are things that you can do to try and maintain participation, for example, by offering sort of home visits or telephone follow-up or indirect follow-up, or by looking at medical records. And if you get consent to access medical records, you can mitigate a lot of these biases. Yeah.
Yeah. So that leads very nicely to the second part that the authors described in terms of how they diagnosed cognitive decline and how they diagnosed dementia. So all of these patients were followed up every 5 years for 20 to 25 years. And during these follow-up every 5 years, the participants underwent cognitive testing. So that included MMSE and some other more detailed cognitive battery tests. They also had health examinations, including measurements of their blood pressure and collection of blood samples. They went through interviews with researchers and completed also lifestyle questionnaires. Most of the tests were carried out by a licensed nurse, or at least guided by a licensed nurse. They also checked particularly the ApoE4 status and then dichotomized the patients into carriers versus non-carriers. In terms of the diagnosis of dementia, so they used a clinical definition. I guess that's quite common for this kind of studies.
I mean, I would expect that here, because you could argue, for example, that if they'd incorporated brain imaging, it might have enhanced their ability to be able to assign subtypes more confidently to the patients, to the participants. But we know that having brain imaging included would have hugely increased the cost. And certainly if they tried to do MR brain imaging, it would have resulted probably in further selection. Yeah. So I think it's perfectly reasonable to use clinical criteria. Yes.
And then that's all based on the DSM-4 criteria.
Yes.
So the authors actually used multiple resources they had, including written computerized medical records and also the cognitive assessments they actually performed when these patients came back for follow-up. What do you think this is the advantage of these sort of approaches compared to approaches where people just rely on hospital diagnostic coding for dementia?
Yes. Yeah, so you bring up a very important point here, Linxin, and this is a study that's set in Sweden, so I can't give you details on the issues around coding in Sweden specifically, but we know that from studies done in the UK and also in the US, that administrative diagnostic coding for dementia is highly specific. So if somebody gets a code for dementia, then we can be pretty sure that they did have dementia. But the sensitivity is not that high. So a lot of patients who have dementia don't actually get coded for it, either in hospital admissions data or in primary care data. So we have to be aware that there's a problem with sensitivity. And allied to that, there's also the issue about coding for subtype. So certainly in the UK, if people are hospitalised for dementia, and my understanding is that this is also the case in the US, is that the subtype of dementia is usually described as unspecified, which of course then it is not possible to use that for subtyping of dementia. I don't know how things work in Sweden. What I will say is that if you have access to more in-depth hospital records or primary care records, you can actually make a diagnosis of dementia according to DSM criteria based on the information that's available in the record for some of the patients. So I think their methodology is very robust in using this multiple sources of ascertainment, and really it is the best way to try and overcome attrition and try and maximise your follow-up for dementia.
Yes. And you mentioned about the split between the type of dementia, so vascular dementia versus Alzheimer's type of dementia. The authors also said that they tried to differentiate between the two types, and the diagnosis of AD, so Alzheimer type of dementia, and vascular dementia was determined by evaluation of what was considered the primary pathology underlying the cognitive impairment. So Sarah, in your practice, do you think it's quite easy to do the differentiation just based on clinical?
That's a very good question, and I think it is quite challenging. Of course, we know from the neuropathology studies that particularly in old people dying with dementia, so we're talking 75 years and above, most people have mixed pathology, so a mixture of different types of neurodegenerative change plus vascular pathology. So I would expect that to have occurred, of course, in the individuals in this study. However, I think it's not unreasonable to assign a predominant subtype. So, for example, in the memory clinic, it will often be clear that the individual sits at fairly far towards one end or other of the spectrum. So based on the sort of clinical presentation and the clinical assessment and the brain imaging, we can be reasonably confident that they've got an Alzheimer predominant subtype, and conversely for vascular. So I think although there are challenges around that, if we're talking about the predominant subtype rather than a pure subtype, I think that's reasonable. Yes.
And the authors also made an effort to exclude people who had unspecified condition or patients who had long-term low cognitive capacity due to trauma or due to stroke or tumor. So they've tried sort of to concentrate on the sort of dominant dementia subtypes. So in addition to dementia, they also looked at episodic memory as a way to measure cognitive decline, so before the onset of dementia. And they used 5 tasks and then came up with a composite score based on these mostly sort of memory test related tasks. Do you think a memory test related or focused task is a good reflection of cognitive decline before dementia?
So, I mean, it's interesting that they've obviously selected these tests, as you say, to be memory specific, and they haven't considered in tests of other domains. For example, the key one would be executive attentional domains. And we might have expected to, in other studies, and the cohort here was not set up specifically to answer this question, but if you were looking at the impact of vascular risk on cognitive decline, you would probably want to include some measures of frontal executive function and particularly of processing speed, because you might expect that to be particularly sensitive. So I think that there's the memory data will be obviously useful, but there are some gaps here that we can't assess executive function.
And obviously they used sort of specific batteries instead of using sub-scores from a more sort of comprehensive cognitive test such as MMSE or MOCA. What do you think the sort of advantage, or if there's any limitation for both of these approaches?
So I suppose doing the in-depth testing of the memory will give you more detail about memory function, and for the MMSE, for example, the memory test is relatively easy, and then on the MOCA it's actually quite challenging. So having more distributed tests like this across memory will probably have less floor and ceiling effects, but on the other hand it will be more time consuming to perform and more effort for participants, and as we discussed, it doesn't give you any insight into other domains.
So moving on to how they looked at cardiovascular risk trajectory over time. So they mainly used the Framingham risk score, which is a score with inclusion of age, sex, systolic blood pressure, medication at the time, BMI, smoking status, and diabetes. And then they entered these risk factors into a formula and then came up basically with a probability of an individual having any sort of cardiovascular disease within 10 years. So they calculated the Framingham score every 5 years when these patients came back for follow-up. And then they and then for anybody who had more than 2 Framingham risk score calculated, they looked at their trajectories and then divided into these divided the trajectories into 3 groups.
Yeah.
So people who have an average trajectory, so these are people who are expected to have kind of risk accumulating over time. So that's just naturally because of aging. And then people who have an accelerated trajectory versus people who have a stable trajectory. So people who have an accelerated trajectory, it's defined as their rate of change is more than 1 standard deviation of the mean. And then if you have a change which is less than 1 standard deviation of the mean, that's people who've got a stable trajectory.
Yeah.
And then they looked at the dementia risk by these groups later. Yeah. So what do you think is the advantage of using the Framingham risk score compared to just using sort of individual risk factors over time?
Well, it's trying to capture a sort of aggregated risk, isn't it? So it's not just the one risk factor, it's several risk factors taken together. So I think it's a perfectly reasonable approach, and it's a well-accepted, widely used score.
Yeah.
We could argue that there are certain limitations to it. One being that different risk factors will have different effects across the lifespan.
Yeah, that's true.
So having hypertension, we know in midlife is bad, but in later life, particularly advanced age, it may not have the same risk associations.
Yeah.
And also that the risk factors are not really quantified as to severity. So another example would be diabetes. So we can think of the lifetime exposure of somebody with type 1 diabetes being potentially worse than somebody with later onset type 2. And then even within those categories, there's huge variation in the degree of control of the diabetes, and things like hypo episodes and episodes of severe hyperglycemia necessitating hospitalisation, both of which are likely to be very detrimental for cognition.
Yeah, so I guess what you're saying is an alternative perhaps would be to have all the blood pressure readings or the glucose readings over time, and then sort of look at the change of that over time as a way to reflect these risk factors and the control of the risk factors.
Yes.
Of course, there are other risk factors that are not included in the Framingham risk score. Is there any other risk factor that is worth considering when people are looking at sort of risk associations with dementia?
Yes, well, I mean, of course, many of them would be sort of non-modifiable. The Framingham includes age, but of course it doesn't include education or occupation.
Yeah.
Other things that are modifiable include things like lifestyle factors. So although the Framingham includes the BMI, of course, it doesn't include information about the level of physical activity or indeed the level of cognitive engagement. So it's really very much focused on just a restricted number of risk factors that have a very vascular weighting to them.
Yeah. So I guess when interpreting the study results, we also need to bear in mind that there are other risk factors that are included that could be important that are not necessarily in the Framingham risk score. So moving on to look at the statistical analysis. So the authors used a Bayesian addictive regression tree model, which is a Bayesian machine learning method. So there are some advantages with this technique, and one of which is that it has a better capacity to deal with non-proportional habits. Also, they seem to be doing better in models where there are lots of non-linear scenarios. So if you're interested in the details of how they used these modelings, the authors have actually detailed their methods in the web appendix of the paper. So I would encourage you to have a read there if you're interested in that part. One thing to highlight is that for their analysis, they've got 2 outcomes of interest. One is the occurrence of dementia, and the other is for cognitive decline. So that's before dementia. For the dementia outcome, they actually included people who were older at entry. So they only included people who were aged 70 or over at entry for this analysis. And for the second outcome, looking at cognitive decline, they then include people who were less than 70 at entry. Do you think that's sort of like a reasonable approach? Could there be any potential bias?
Drawbacks, yeah. So, I mean, we did discuss this, didn't we, Linxin? And we were quite, we thought it was an unusual approach. We thought it was not unreasonable to focus on the older participants in terms of dementia, because as the authors point out, it is a disease largely of older people. we thought it might have been interesting to undertake some sensitivity analyses to include younger people as well as the older people in the dementia analysis, and conversely to include the older participants in the cognitive decline analyses, and really just to see whether they got similar results, or even with the latter to look at just the two groups stratified. So look at the cognitive decline in the younger participants as they have done, but also to look in the older participants, because I think that would have been interesting to see whether the same associations were seen irrespective of age. So that was something that I would have perhaps liked to see here.
Right. So that's just the methodology of the paper, and we've covered some of the limitations we think the methodology may have, and also what we are going to look at next as the results. So overall, they had 117 patients with diagnosis of dementia over time. Most of them were of Alzheimer's type of dementia. So 78 were of Alzheimer's type of dementia and 39 were of vascular dementia. So they looked at the results in two ways. The first way is they looked at the absolute risk of dementia stratified by the three trajectories that we talked about earlier. So accelerated, average, and stable. So in terms of the absolute risk for Alzheimer's type of dementia, the absolute risk reduction across the whole sample was 2.7% for those in the average group compared to those in the accelerated group, with a number needed to treat of 37. And the absolute risk reduction was 2.5% for those in a stable group compared to the accelerated group, with a number needed to treat of 40. So that's for Alzheimer's dementia as well. And then for vascular dementia, both the average and stable group had an absolute risk reduction of 3.4% compared to the accelerated group, and with a number needed to treat of 30 for both comparisons. What do you think the sort of clinical implication is for these numbers? This is not a trial, obviously.
No, it isn't. So, I mean, obviously we have to bear those caveats in mind, but I think the authors are trying to make the point that if you can potentially intervene to change participants from accelerated trajectory group to a stable or average group, then you can produce benefit in terms of a reduced rate or reduced risk of dementia. And of course, in the absence of any reliable treatments for dementia, this is important to understand. And it gives you some feel for the magnitude of the effect and how many people you would need to be successful in to see an important difference.
In terms of their data for this absolute risk difference with the trajectories for Alzheimer's dementia and vascular dementia, we were both quite intrigued, isn't it, by their figure 3, which shows quite a different time course in terms of the risk associations. We thought about sort of potential reasons.
We did. We looked at this because we compared the trajectory or the cumulative incidence curves for the Alzheimer's type dementia and the vascular type dementia. And whilst both showed differences in cumulative incidence by the Fronian trajectory, with both showing the accelerated group had the highest incidence of dementia, the thing that we thought was slightly difficult to understand was that the curves were somewhat different in shape. So whilst there was a very early high risk for the Alzheimer's dementia outcome, that was less obvious in the vascular dementia outcome. And we wondered whether this was something to do with the exclusion of people with cognitive difficulties after stroke, which was referred to in the methodology. But we weren't really quite clear whether that was joining the study or whether it meant that people were excluded on follow-up. But
as well,
if the latter, then it might explain why the curves are different between vascular and Alzheimer's type dementia.
It's certainly very interesting if the time course is different, because then it means the intervening period will be different.
Absolutely. And the time at which you need to wait before you see a benefit will be greater.
So this is the first part when they looked at the absolute risk difference. And for the second part, they looked at the relative risk in terms of comparing the different trajectory groups, and they calculated a range of risk ratios. So they looked at first comparing accelerated to stable trajectory, and the cardiovascular risk trajectory predicted an increased risk of developing Alzheimer's disease dementia with an average risk ratio between 3.3 to 5.7. And for vascular dementia, with an average risk ratio of 3.3 to 4.1. And the same results was found for the other outcome, which is looking at cognitive decline.
Yeah.
Is it expected that the risk ratio is similar for Alzheimer's dementia versus vascular dementia, or you would expect the risk ratio to be slightly different?
We might have expected a higher relative risk in the vascular dementia outcome group, but I think that's probably explained by the difficulties we alluded to previously about defining clinically vascular versus Alzheimer's dementia. So I think probably we can't read too much into those differences for that reason. And I think the other thing that we noticed in the paper was that the relative risks were higher in the early parts of the study and later on. And we thought probably that was partly because of just people aging and then dying or just otherwise lost to follow-up, that there might have been just fewer people around to measure an effect in.
Yeah. And the last part of the results that's quite interesting is the analysis stratified by the ApoE4 status.
Yes.
And maybe of all of that, the most exciting finding they showed was that for people who have a carrier status, if they have a stable trajectory, so if they do well in terms of vascular risk factor control, then their risk of developing dementia was similar to people without the risk status with an accelerated risk trajectory. Do you think that's
yes, I mean, I think what the important take-home messages are, as you say, so that if you do have an ApoE carrier status as an individual, we know that overall you're at higher risk of dementia. But I think what this article confirms is that nevertheless you can do something about that risk by, if you have a stable or an average trajectory, particularly if you have a stable trajectory, you can nevertheless reduce your risk in comparison to carrier people who have an accelerated risk. Another important point, though, is that in the ApoE carrier group, there was less difference in risk in people who had an accelerated vascular profile versus people who were stable or average, whereas in the non-carriers, there was a bigger difference between people with accelerated versus stable vascular.
I guess your susceptibility is also
different.
The
susceptibility would be different, and the risk, the baseline risk would be different. So that was interesting.
So that's basically the main study findings, isn't it? And so overall, the findings of the study basically suggested that the relative trajectory of cardiovascular risk is a significant component when you look at risk of dementia at older ages or sort of developing cognitive decline at younger ages. And we've talked about some of the limitations of the study already, and the authors also pointed out that the way to differentiate Alzheimer's dementia versus vascular dementia is one of their limitations. And they also commented that they were not really able to look at some other factors, such as the deposition of tau as a mediating factor between the associations.
No, that's right.
So overall, what do you think is the sort of clinical implication, or what we can do from now?
Well, I think it suggests that it emphasises again that trying to sort of control vascular risk is very important in terms of reducing dementia risk. And we think that better control of vascular risk factors is one of the reasons why age-specific incidence and prevalence of dementia have been declining in developed countries over the last 2 decades. So I think it's really a very positive take-home message, is that there are things we can do to reduce risk. And I think the other thing that it leads on to is that future studies really need to start looking at these more dynamic risk factor exposure measures, rather than just looking at cross-sectional one-off measures in time. And as you alluded to, we can think about now, especially with the arrival of electronic records, is to whether we can start pulling large amounts of data, for example, on blood pressure exposure over time, or on diabetic control over time, for example, to get better measures of the lifetime exposure to these vascular risk markers. And I think one of the other things that we as clinicians thought when we were looking at this paper is that it's often quite hard to understand the progress of individual participants through these serial studies, and we talked about the issues about attrition, and I think we felt we would have liked to have seen a bit more detail on the numbers of participants attending at each follow-up, and how many people managed to attend multiple follow-ups versus maybe only one or two, because that would have given us a better feeling as to really how much data there was to be accurate about assigning trajectory into an accelerated or a stable group. And so that was the only other thing that we noted that we would have liked to have seen.
And I guess the techniques we also said that they used to sort of reflect the trajectory could be a useful thing for people to consider if they were to look at trajectories of similar stuff in the future.
Yes, that's right. Yes. It's clearly an area of ongoing interest and definitely an area to be exploited in future studies. Yeah.
So thank you very much for dialing in, and so this is the end of our journal club discussion, and I hope you will find the paper interesting, and congratulations to the authors again on this nice study. Thank you.
Thank you, Linxin.